Thank you for giving the opportunity to talk about osteotomies and stem cells for medial unicompartmental osteoarthritis. Osteoarthritis of knee patients, cartilage defect is accompanied frequently with varus malalignment, and treatment should be combined with correction of malalignment, otherwise success rate will be far worse than expectation. For the treatment of osteoarthritis knee, cartilage repair, high tibial osteotomy, joint replacement could be performed. For the cartilage repair, currently several methods is available, such as microfracture, autologous chondrocyte implantation, ACI, and stem cell. Microfracture is very simple, easy, and widely performed technique, but repaired fibro cartilage is inferior biochemically and showed deteriorating result after 2 to 3 years, and its effect in high-grade osteoarthritis of knee is yet to be proved. In order to improve the result of the microfracture, augmentation is introduced. Its role is augmentation of the mechanical stability of early clot and retaining more mesenchymal cell-rich blood in the defect. Many types of augmentation exist, such as scaffold augmentation only, scaffold with cell-type augmentation like chondrocyte, pluripotent stem cells, mesenchymal stem cells, and growth factor augmentation, and cytokine modulation. BMAC is one of the most popular options. However, it has a limited number of stem cells, less than 0.01% of mononuclear cells, and there are limited available outcomes data in literature. This is photos for BMAC protocol. 40 cc bone marrow was aspirated at the contralateral anterior superior iliac spine and centrifuged for 15 minutes. Now I'm going to talk about comparison of microfracture alone and microfracture with BMAC augmentation for medial unicompartmental osteoarthritis. Between January 2005 and December 2015, 83 patients underwent HTO and arthroscopy with microfracture only or combined with BMAC for medial unicompartmental osteoarthritis. Among these patients, 47 microfracture alone groups and 34 microfracture with BMAC groups were included. Also, second look arthroscopy was performed at a mean of 1.5 years. In clinical outcomes analysis, Hospital for Special Surgery, HSS, and Western Ontario and McMaster University's WOMAC scoring system were different between two groups in statistically analysis. Second look arthroscopy was performed after 1 or 2 years. Status of cartilage regeneration was reevaluated according to ICRS assessment scale. An overall ICRS score were much better in BMAC group than microfracture alone with significant difference. In conclusion, microfracture with BMAC augmentation is more effective for cartilage regeneration than microfracture alone in medial unicompartmental osteoarthritis. However, clinical outcomes were improved regardless of BMAC augmentation. This is a demonstrating case. 57 years old female patient showed right medial unicompartmental osteoarthritis with varus deformity. In intraoperative finding, we could confirm cartilage defect of ICRS grade 4 of 10 by 20 millimeter size, and we performed microfracture only. After 1 year and 9 months, mechanical access was satisfactory. However, in second look arthroscopy, regenerated cartilage tissue was hardly seen. This is another case. 44 years old male patient showed right knee medial unicompartmental osteoarthritis with varus deformity. In preoperative MRI, we could see severe degenerative change of medial compartment. An arthroscopic exam confirmed wide deterioration of cartilage of medial femoral condyle.
Vous pouvez avancer la communication, s'il vous plaît?
In this case, we treated cartilage defect with BMAC augmented microfracture. Defect size was 1.8 by 5.6 centimeter. After 2 years, lower leg alignment was excellent. And second look, arthroscopic findings showed well regeneration of cartilage defect with mild softening. As we observed, cartilage repair with microfracture was still unsatisfactory. So we need to have a better method of cartilage repair. Human umbilical cord blood-derived mesenchymal stem cell, HUCV-MSC, so-called CARDSTEM, seems to be very promising. A number of mesenchymal stem cell is 7.5 by 10 power 6. We can see mixture of mesenchymal stem cell and higher uronic acid in the syringe just before clinical use. Now I'm going to talk about our study of second-look arthroscopic findings in kissing lesion comparing BMAC and CARDSTEM. Between January 2015 and December 2019, 150 patients underwent ATO and arthroscopy with microfracture combined with BMAC or CARDSTEM procedure for medial unicompartmental osteoarthritis. Among those patients, 42 BMAC groups and 32 CARDSTEM groups had kissing lesion, which was shown as ICRS grade 4 in medial femoral cartilage and medial tibial cartilage. Also, second-look arthroscopy was performed after mean of 1.5 years. In demographic data, variables including sex, age, BMI, defect size of cartilage, hip, knee, ankle axis, and posterior tibial slope were shown no significant difference between two groups. In clinical outcome, there is no significant difference between two groups except HSS score. Cartilage regeneration of medial femoral condyle was better in CARDSTEM group than BMAC group with significant difference. Especially, there were 6 cases of cartilage regeneration of ICRS grade 1 in CARDSTEM group. And also, cartilage regeneration of medial tibial condyle was better in CARDSTEM group than BMAC with significant difference. In conclusion, several methods in clinical use are existed for cartilage repair needing more clinical evidence. But in our study, CARDSTEM was more effective for cartilage regeneration than BMAC in kissing lesion, and clinical outcomes were improved in both treatment of BMAC or CARDSTEM. This is another case of CARDSTEM. 56 years old male patient shows severe degenerative change of medial unicompartment. In intraoperative arthroscopy, almost complete loss of articular cartilage of medial femoral condyle and tibial condyle was observed. And we performed cartilage repair with CARDSTEM procedure. After 2 years, we could see good alignment of mechanical axis and perform second-look arthroscopy. In second-look arthroscopy, we could see well-regenerated articular cartilage of medial femoral condyle and tibial condyle. Thank you for your kind attention.